Welcome back, everyone. We're going to continue our discussion with a two-part series on other pediatric emergencies. We divided some of the other pediatric emergencies through cardiovascular, neurologic, and others. This kind of gets some of the emergencies that don't fall into any of those categories very well. Firstly, let's talk about biliary atresia. This is where the biliary tract is malformed so that the bilirubin can't be excreted. This leads ultimately to liver disease and failure. And transport children with massive GI bleeds, for transporting children with massive GI bleeds, make sure you obtain IV access and administer fluid boluses. This would constitute a potential state for hypovolemic shock. Viral gastroenteritis is the infection that can be caused by a variety of viruses and ingestion of spoiled food or certain foods and substances. Presentation is typically associated with nausea, vomiting, and diarrhea. If you suspect dehydration, administer fluid for provider levels that are capable of doing so. Appendicitis, this can lead to peritonitis or shock if it's untreated. Fever and abdominal pain are common. These patients should be transported immediately to the emergency department. You may find rebound tenderness upon assessment of the abdomen, particularly in the lower quadrants, but note that that's not the only sign that may be present for appendicitis, and that's not specific to appendicitis. So don't rely on a physical exam of the abdomen to rule out or rule in appendicitis directly. Ingestion of foreign bodies. This is where a foreign body is lodged into the esophagus, and it can cause gagging, vomiting, and difficulty swallowing. If it's in the airway, it can create choking and would be classified as a foreign body airway obstruction. For ingestion of foreign bodies, try and keep the child calm and comfortable and transport to a facility for facilitation and removal. GI bleeding or gastrointestinal bleeding, if it is ingested, if it's in the upper digestive system and it moves through the digestive system, you may see things like coffee ground colored emesis, or if it's in the lower GI system, you may see things like dark or tarry stools. It's not uncommon that blood is ingested during the childbirthing process, so the first or second or few stools after childbirth, you may see some digested blood material. It's also common that blood is ingested from epistaxis or nose bleeding after surgery, or episodes of forceful vomiting. Another cause of gastrointestinal bleeding in children are anal fissures from constipation, or hemorrhoids or irritation in the lower GI tract from repetitive diarrhea in the infant or neonate. Intussusception is when the bowel telescopes into itself. This is generally hallmarked with intermittent severe abdominal pain. It can also have currant jelly looking stools. It's not really able to miss when you see the bowel material and it looks like that currant jelly or bloody stool. You should suspect intussusception, and that's a surgical emergency that requires immediate transport to a facility. Meckel's diverticulum. This is a congenital malformation in the small intestines. Patients typically present with painless rectal bleeding or hematochezia. Transport to the ED for further evaluation. The patients we use the rule of tools to kind of describe this, and that it occurs in about 2% of the population. It has a 2-to-1 male to female ratio. Typically, it's located geographically in the bowel within 2 feet of the ileocecal valve. Commonly, it's 2 centimeters in diameter and 2 inches in length. Contains 2 types of ectopic tissue, and they're typically symptomatic by age of 2. Not that you're expected to remember all of those, but that's what we're talking about when we refer to the rule of 2 there. Pyloric stenosis and malrotation of the volvus. With pyloric stenosis, the pylorus becomes hypertrophied, and patients will often present with projectile vomiting after feeding, and surgery is the curative measure here. Malrotation of the volvulus is the twisting of the bowel around the mesenteric attachment within the abdominal wall. It presents with bilious emesis, pain, and distended rigid abdomen, and is a surgical emergency. Consider the following with gastrointestinal emergencies. You want to consider the age of the patient, the gender, whether or not the child was born prematurely, any current medications, or history of similar complaints. Assess and reassess location and severity for abdominal pain. Premature infants with those symptoms in the first weeks of life require more extensive evaluation, and there's going to need to be further workup for those patients within the receiving facility. Give special consideration to patients with G-tubes, and we'll talk about pediatric special cases in a separate lecture. But you may need to inquire historically and then evaluate or assess the area around the G-tube placement to make sure that there's not an underlying infection or other problem. If you need to replace the G-tube, you need to lubricate the distal end or the end that's being inserted into the os. Gently press the slide into the tube of the stoma and then tape the replacement into place. And then you're going to need to transport that patient for definitive treatment and replacement of the G-tube. Make sure you assess for dehydration. You can ask the caregivers on scene how frequent diaper use has been. Has it been more frequent than normal or less frequent than normal? More frequent diaper changes or may indicate a state of progressing hypovolemia, so that may lead to a state of hypovolemia, while less bowel movements, less urination may indicate an existing state of hypovolemia. Ask about intake. Is the child feeding normally, drinking normally, able to take in fluids? Make sure that you're not giving things orally to the patient until we can get a further assessment done to make sure there's not underlying structural causes that can create problems for the patient later. Hyperglycemia can be a result of severe dehydration and DKA if it's not promptly treated. During assessment, you're going to typically find that a dose of insulin had been missed or a normal portion of food was eaten or there's an insulin pump malfunction. During assessment, ask about insulin administration, the insulin pump, any changes in urine output. Hyperglycemia or states of high blood glucose are typically characterized by polyuria, which is excessive urination. They may or may not be presence of urine ketones. Ask about recent blood glucose checks. So the patient should be taking glucose readings at home, or a caregiver should. And then inquire about other symptoms that may be different from normal presentation. And that can include things like headache, visual changes, abdominal pain, vomiting. You want to inquire a decent historian on scene, so a caregiver, patient, etc. For treatment of hyperglycemia, you're going to provide 100% O2 if the patient is hypoxic, or if assisted ventilation is needed, monitor vital signs closely. And then for advanced level providers, IV access and isotonic fluid to help dilute some of those excessive fluids or excessive sugars. If patient reports worsening of headache or mental status deteriorates, discontinue your fluids and be concerned about increased intracranial pressure. ECG for paramedic providers. Hypoglycemia. This is common across all age ranges, but if you're in pediatric patients, assessment and treatment is the same. Assess the blood glucose levels. Remember that infants and children don't have the capacity to store glucose as well as adults, so they're more susceptible to hypoglycemia. And this can lead to irreversible brain damage. Assess and treat accordingly. Look for early signs, things like irritation, agitation. Later signs can include things like cool, pale, and clammy skin, tachycardia, tachypnea, abdominal pain, dizziness. Severity is going to depend on blood glucose levels. Maintain ABCs, right? For advanced level providers, establish your IV access and give normal saline at a KVO rate. You may need to consider to administer a fluid bolus while administering glucose, and repeat your BGO readings about every 10 to 15 minutes. For EMT basic level providers, you can consider things like oral glucose if the patient is able to swallow and able to consume, or encouraging feeding if the patient is breastfeeding. CAH, this is congenital adrenal hyperplasia. This is an autosomal recessive disorder of an enzyme responsible for the metabolism of cortisol and aldosterone in the adrenal glands. It's most commonly due to 21-hydroxylase deficiency. Males born appear normal, although some may exhibit signs of puberty as toddlers, including increased musculature, penis growth, pubic hair, and lowering of the voice. And females may present in a masculinized presentation. So things like an enlarged clitoris that resembles a penis. Congenital adrenal hyperplasia, some of these patients will undergo early puberty develop, as we spoke about earlier. You may also see early growth acceleration, development of facial hair, and a short stature. When the child becomes sick, the body may not always be able to appropriately compensate, and so normal mechanisms of compensation or assessment of compensation of cardiovascular status may be impeded for these patients. Infants may have vomiting, poor weight gain, and dehydration. If suspected hydrocortisone and IV boluses of normal saline are needed, you're going to have a hard time diagnosing this in the pre-hospital world, but this may be a complication of a known diagnosis within this patient. You may want to reach out to medical control for advanced level providers if you have steroid use available to you in consultation for administration. Panhypopituitarism. With hypopituitarism, this is where the pituitary gland doesn't produce normal amounts of some or all of its hormones, and panhypopituitarism is an adequate production or absence of the pituitary hormones. When they're stressed or sick, these patients can present with symptoms similar to CAH. Patients are going to predominantly require supportive care, but in addition to that, you're going to need glucose replacement therapy for these patients, and advanced level providers will need IV boluses with normal saline. Replacement of steroids with IV hydrocortisone will be in hospital treatment. Management, these patients will most likely be undergoing management with a pediatric endocrinologist, and once hormone therapy is initiated, children can generally live a normal life. I would encourage you to get your history from your care providers on scene, and these patients may have specific needs and or requirements where they can see their physician, and so they may need to go to specific facilities in the area, or they may live in an area where may not be the closest facility to you, but they need to go to a specific area where these patients are being managed. Inborn errors of metabolism. This is a group of congenital conditions that cause either an accumulation of toxins or disorders of energy metabolisms within the neonate, and it's characterized by a term known as failure to thrive. And this is kind of a vague sort of reference, but it's an infant that doesn't really want to eat, doesn't eat well, is not gaining weight. It's just not doing well. It's failing to thrive. These inborn errors of metabolism, they're grouped into two categories. Disorders that result in toxic accumulations, and then disorders of energy productions. One of the common ones for the disorders of result in toxic accumulation are things like maple syrup urine disease, which is a genetic disorder that causes a buildup of amino acids within the urine, and then disorders of energy production like hereditary fructose intolerance, which is a lack of a specific enzyme, aldolase B, which is the enzyme responsible for breaking down fructose. So they can't break it down and can't digest fructose into a usable form. Symptoms can vary, including loss of milestones in development, recurrent vomiting, diarrhea, skin problems, dental deformities, deafness, and blindness. Dietary restrictions and replacements can control many of these disorders. Boluses of glucose and the use of D10 fluids may be necessary for these patients. And again, it's going to be based on history and presentation of the patient.